So in terms of this chapter, it was actually, I can't take credit for the idea. It was actually one of my buddies from med school. He's a neuroradiologist of University of Chicago. And he, with other neuroradiologists, myself, Dr. Escuian, and a couple other people, we decided that we don't always understand what's happening post-op. You know, you're always excited, you know, to go to the operating room, but what happens after you're done in the operating room? So I have no disclosures. So what's the goal of a successful spine surgeon? We're all here. We've heard all the greats telling us, what do we need to do? What do we not need to do? What do we need to do? Our goal is to give excellent care to all our patients, right? But more importantly, it's not knowing only when to operate, but it's also knowing when not to operate. So for me, one of my mentors previously coined the term, the decision's more important than the incision. And once we decide we need to operate, what will I find? What am I getting myself into? Perioperatively, you're already now in the OR. Am I at the right level? Is my instrumentation placed correctly? Is everything removed that should be? Postoperatively, am I at the right, is my instrumentation still at the right spot? And how does my construct look? And of course, can I sleep at night? So as we learned over and over again, and we all have the t-shirts, we have to follow our 10 commandments and we have to understand our imaging. So this is an image I saw online on social media a couple weeks ago. And I'm looking at it and I'm like, something's not right. So what do you guys think is not right? Anyone? Is that what's not right? Actually, I looked at it deeper and actually went to the website. It's a superimposed image. It's actually not an operative image. So your patient's gonna come to you in clinic with something like this and say, why do you wanna operate on me? Look what could happen to me, right? So you have to be able to understand and actually be able to differentiate good surgery, bad surgery, or fake news, as you would see here. So before you go to the OR, you gotta be prepared. Okay, you got to do all your preoperative work beforehand. You have to know what to expect. You have to know if you have all the tools. Not every case is going to be your re-op. It might be from someone in the community. It might be from another surgeon across the street, or it might be from your partner. So we don't all use the same instrumentation. We don't use all the same tools. What does our spine look like? What are my goals? Where could I fall into this trap and be fooled? And what, in case of a disaster, what is my exit strategy? You know, you've seen all the greats put up all these beautiful scans, but what you don't see is when something went wrong in the OR. What could I do to get the patient safely off the table? So you have to have a PERiscope. In the perioperative time, you have to rely and understand the radiology, whether it's through navigation, through fluoro, whatever it is. In my institution, whenever we use navigation, I don't let the residents use navigation until they tell me where their starting point is. Because if you rely on navigation, whether it's cranial or spine surgery, your long-term, you're gonna fail. Someone's gonna come in the OR, kick off the cord, and then what do you do, okay? When you're in trouble, or even when you're not in trouble, step away from the wound, pay attention to your radiology. We are not perfect. And the one word the one phrase I hate in the OR is, I think it looks okay. That is the key phrase that you're in trouble, okay? If you think it looks okay, then get another image and be 100% sure it looks okay. And if all else fails, trust your knowledge of the anatomy. You know, I'm sure we could flash Dr. Tubbs' cell phone up here, and if you get in trouble, just give him a call. And then post-operatively, what happens? Your post-operative imaging. Every place you go, every attending you talk to, they're gonna say different things about post-operative imaging. Some people get CTs, some people get x-rays, some people don't get anything at all. So when you do get it, when, for what do you expect, and what are you gonna do? So we're gonna go through some cases, see what everyone has learned throughout the weekend. Feel free to shout it out. If no one knows the answer, that's fine too. So what's this a perfect example of? Anyone?
I think someone try to do a laminoplasty and bend this plate too much and put it in or something?
Surprisingly, it's actually a good laminoplasty, but it is a laminoplasty. That's the problem of us not seeing a lot of them. Here's a patient post-operative, and this might be a patient Dr. Newell recently described. What is that arrow pointing at? So that's a duroplasty. It's someone that sewed in a graft. Will you know what it will visualize post-operatively? So here's another example of a patient that's been followed through the years. This patient never had surgery, and the disc went away. And these are all actual cases. So you have to think in the back of your mind, when and what are we doing? Do we always have to do something surgical? Now here's a very common case. Patient wakes up post-op after a discectomy, and they're still having this pain. And what do? You get an MRI. Well, that arrow is actually Surgicel, not retained disc. Here's an example of a cage with some subsidence. On the left is a well-put one, and on the right is one that subsided over time. How about here? What do we have here? Something pretty easy. What do you guys think?
I think something from the lower leg, I think Fibular?
Yep, it's a fibular strut graft. You know, you'll see a lot of these throughout your career, depending on what institution you practice at. Now, this is more of a little bit of a disaster. This is a dislocated bone graft with many other things going on. So there's some things you don't want to see on your postoperative imaging. Here are some stackable cages. Now, here's some this is back to Emra's talk earlier. You've got some bone graft, and here's what your iliac donor site would look like. Not many people image that postoperative. Is that a good image? Is it a bad image? So you have to know this patient had no pain. They just got an image there and decided to look at it. And here, these little objects here, they're all bone chips, right? You have to make sure they're not in the middle of the canal, but that's a good image to see postoperatively. And ultimately, here's our goal: mature bone fusion. DBX in bone. And then here's some BMP-induced osteolysis. So this is a very common, probably maybe not your best ACD, but this is a good example of an ACDF. But there are many different modalities to do ACDFs nowadays. You know, if we've been talking throughout this weekend, you could do standalone, okay? So does anyone know what this is? So this is the LDR system, the ROIC. What's important is if you would need to do a post-operative, or you have to go back to this, you have to know what you're getting into, how you take it out, and have a plan rather than go in there and say, what do I do next? So some other stuff you may see. Some of the stuff you're going to see here have been put in over the course of the last 20 to 30 years, but that does not mean that you're not going to see it in your ORs nowadays, especially if you become big deformity surgeons like everyone in here wants to, and you have to take out some older instrumentation and older devices. You have to have a solid plan. So here's your Canada device, followed by a Vantage plate. This is an easy one. What are these things? Even though not, yeah, these are just some hooks that you could put in. This is a fusion device that, depending on your institution, some people may use it or may not. Do you guys know what this is?
Yeah, facet screws.
Yep, absolutely. Someone watched my video from last year. Here's some sounder cables. So we talked about all the different, if you listen to Dr. Kazemi's talk, he talked about all the different modalities to fuse all the way from back in the day to now. Here's the Lukey rod, here's a Harrington rod, and here's a knot rod. And here's a schematic of all the different ones. And would you be able to differentiate between all of those if you were looking at them in your office? You know, the go-to thing, and if you look at a lot of radiology reads nowadays, they'll just automatically go to Harrington rod. So if you go by that and you're in the OR, are you going to know what to do, where the actual rod is inserted versus not inserted, and what do you have to do next? You know, if you have a pediatric population, you may end up with some vertebral stapling or the VEPTR device. Now, interbody fusions. This is one point I harp on all my residents is knowing which way the cage went in. Because if you don't know which way the cage went in, you may not be able to get it out. So this is an older threaded cage. These are the old LT cages by Medtronic. So this is a PLIF cage. You know, do you know the difference between a PLIF and a TLIF cage? Anyone? So the main difference is the angle at which it goes in. And you have to be able to recognize that if you're going to try to do a revision surgery. If it's a first-time surgery, that's really easy. But when you start doing revision surgery, that's a little more important. Here's another one that was not optimally placed. This one we spoke about over the course of the weekend as well. This is a laterally placed cage. This is the same exact thing, but with some screws. You could also, the spine, you could reach it 360 degrees nowadays. Here's an anterior cage. What's going on over here? So that's a cage that's spit out, and it's not the most ideal placement. Could have happened while they flipped, or it may have just never been put in correctly. Nowadays, I don't know how Dr. Escuin feels. I put some sort of device there to make sure whether it's a plate or a buttress screw, just so it doesn't pop out. I never leave them standalone. This is a classical one. Does anyone know what this one is? It's the axial lift. Harder than putting it in is actually taking it out in a revision. So arthroplasties, we talked about it at length over the course of the weekend, but there are many different devices. What if you need to revise one of these? Are you able to recognize which ones they are? You know, I think one important thing is when you review your anatomy and your scans preoperatively, if you have to do something about it, go to the company website, go to wherever you need to do, but figure out what it is you're getting into to figure out how to get it out. Here's the Charité by DePuy, the ProDisc by Synthes. They all kind of have a radiological fingerprint that you should be able to differentiate between all of these. And this is something you typically don't want to see on your post-operative imaging. This is an image from one of my colleagues that was about 2 months later. And, you know, you put in a artificial disc, and what happens? It fuses. So you have all these posterior dynamic stabilization devices as well. You have the isobar, you have the X-stop, and then you have the interspinous spacer by Medtronic, which is called the DM. Do you guys know what this is? This is a little more common these days, depending on what institution. Yep, Coflex. Very good. And this is a Coflex that, well, didn't really retain its proper alignment there. Have you guys seen the dynamic facet replacement device? I mean, these are probably aging about at least 15, 20 years, if I'm not mistaken. And then you've got dynamic rods. So what could be in my way? So you now figure out what instrumentation you have there. What's next? You have to figure out what you could get yourself into while you're on your way in. You never want to sit there and find half a catheter from a pump or half a stimulator from a spinal cord stimulator, right? You have to pre-plan these things. You may have to turn them off. You may have to turn them on, talk to the reps, talk to the patient, obtain other information from everyone. Now, the stuff we don't want to talk about, complications. You know, your surgery went great. It's 11:30, 12 o'clock at night. you know, all of a sudden you get paged and you have, you know, a scan. Do you know what to do with the scan? Because you have to call Dr. Escuin and wake him up. And if you don't know exactly what you're talking about, he's not going to be really happy waking up at 12:30 at night. Some of these things you're not going to see at 12:30 at night. This is a pseudoarthrosis, but you do have to recognize it in your clinic. Here's a broken screw. How about this one? This was a patient I saw during the course of my training. So this patient had a lumbar laminectomy and woke up with a cauda equina. So what happened here is there was a durotomy, and when the dura was closed, it was closed too tightly. Okay? We got a stat MRI, and because we were there intraoperatively, we knew what to do afterwards, and we took the patient right back and we sewed in a dural patch. Stuff you don't want to see are spinal cord infarcts, but you also have to be able to recognize them. You don't want to operate on a spinal cord infarct. It's poor form on your boards. It's back to what Dr. Newell was saying, you know, about an hour ago. You have to recognize what you see. If you're not sure, get another scan. This is a not so well-fixed pseudomeningocele. You don't want to see that on your post-operative scan, even less so on a myelogram. This is probably the most common one that's the most difficult scan out there. Patient wakes up, you don't know, you know, they might be a little older, they're not dealing so well with the morphine, they're not really moving their legs as well as they were pre-op, and you get this. And then the radiologist reads it as clinical correlation recommended. It could be clot, it could not be clot, it could be this, it could not be this. So you have to know and recognize these and say, hey, do we need to do something about this, or are we just gonna stick around and wait it out? This is a little bit more of an emergency. It's supraglottic swelling. You may see it very often in your post-operative ACDs. Post-operative discitis and osteomyelitis, knock on wood, it's happening less over the course of the past few years, but it's still something that needs to be recognized. And the worst is an epidural abscess. How about this? Let me see. That doesn't work. I don't have the magic trick Dr. Chapman does, but what are these things here? Have you guys seen these before? I heard something. Beads, yeah, they're antibiotic beads. Some people put them in for post-operative infections. They're tobramycin, and I actually add vancomycin as well. You know, depends on your training and where you are. I believe that as a last resort, it could help, especially when you start involving plastic surgery, they put a wound vac and all that. I leave them in for about a week or two. This is not the true meaning of tricortical. You do not want to incorporate the aorta. If the aorta has more calcium than the bone, you might want to rethink your fusion. Sometimes a patient will wake up. You'll see a little bit of hyperdensity on your CAT scan. This turned out to be a retained bone fragment. Went in, patient did great post-operatively. How about this? This is one you may not see as often. So this is a retained drill bit, okay? You don't expect to see that, you know, keep that in the back of your mind. Who knows what a Gossi fiboma is? Anyone? It's a retained sponge. It's what the lawyers will refer to if you retain a sponge. They're not going to tell you you've got a retained sponge. So that's something you do not want to see. Other stuff, you know, you do enough kyphoplasties. This is what you try to avoid. You do not want cement extravasation, especially not going up to the lung. So in conclusions, you have to really, really understand your images in all stages, before, during, and after surgery. Anytime you have an x-ray or whatever is happening in the OR that you do not feel comfortable with, if you remember Dr. Uribe pointed out the lateral cage or that case yesterday, he didn't have that individual who he was referring to did not have a perfect x-ray. It wasn't a perfect AP. It wasn't a perfect lateral. What happens? You are working, you're trying to create a three-dimensional image from a two-dimensional image. If you don't have perfect orthogonal planes, you're going to be off, okay? When the people who came to our lab session yesterday that were at the percutaneous one, you always want perfect images, crisp end plates, know where your pedicles are, know where all your anatomy is. Don't say it looks good enough. You need to know it before, during, and after. How do you do that? Well, look at it as many images as possible. As a resident, a fellow, you have access to every single attending's, every single case, right? It doesn't matter if you are doing that case, you're not doing that case. Create your own data bank. Say, this went well, this didn't go well. I did this and this went well. Someone else did this and this went well. Someone else did it and didn't go well. That doesn't mean you have to gossip about it, but create it in your mind. That way you know what happens, when you're actually faced with the situation. The images do not lie at any point. Make the necessary corrections when necessary. And of course, you got to learn from the bad and the ugly on your journey to become great. So this book isn't just for spine. For the neurosurgeons, it actually includes many cranial chapters as well. It's a plug for my friend. So these are the people that helped me write the chapter. And in case you're wondering, for the spine fellowship here, they're taking applications really early. So this is an application for 2054. So thank you all. Hope you all had a great weekend.